So, good morning, everyone. Good morning to our Nepal team, and good evening to our Canada team as well. And I thank our Nepal team for giving me this opportunity to present today. So, today we'll be dealing with opioids and pain management in children, as well as procedural pain in infants and children. Coming to the objectives, today I'll be talking about how to treat pain using WHO guidelines regarding safe use of opioids and procedural pain management. So WHO has given this guidelines of who should be treated using this WHO guidelines, and these includes children who are like suffering from cancer and cancer related pain, for other palliative care patients such as like end stage heart, kidney, liver, lung diseases. It can also be used for children who are suffering from cerebral palsy, a muscular dystrophy such as Duchenne's muscular dystrophy or Becker's muscular dystrophy. It can be used for neurodegenerative conditions such as adrenoleukodystrophies. It is not recommended for patients who have chronic pain if they do not have cancer or other palliative care illnesses. So chronic pain conditions are not to be like treated using these guidelines, which are not like cancer related or palliative care illness. So this is just a picture globally of distribution of illnesses in children who require palliative care. So this is something you have already seen in the previous sessions. So cancer only like comes to 5.7% of all the palliative care need conditions. One major like group is congenital anomalies, like it can be CNS anomalies such as anencephaly, holoporencephaly, etc. Neonatal conditions come around 15% and HIV/AIDS come around 10%. So before going into the treatment part, I'll just talk a little bit about WHO principles of pain management. So WHO principles of pain management, the principles are by the WHO ladder. So we have a two-step ladder for pediatric children, pediatric patients. Then the second principle is by the mouth. By the mouth is the most like safest route to give opioids or any other medication. Third principle is by the clock. So every medication has to be given based on the time of its action. So it varies with drug to drug. For opioids, for example, morphine, it has to be given every 4th hourly. And we have to also talk regarding the PRN doses. The fourth principle is by the individual. So the treatment or the pain management should be individualized according to the child. The fifth is adjuvant therapies. So adjuvants are co-analgesics that can be given along with the main pain medications. So under adjuvants, you have corticosteroids, you have tricyclic antidepressants, you have anticonvulsants such as sodium valproate. And the last is to prevent side effects. So we'll be talking a little bit about side effects, and we have to keep in mind how to prevent them and how to avoid them so as to provide good quality care. So by the ladder. So the new WHO guidelines of 2012 has given a two-step ladder. This is different from adult, where there is a three-step ladder which was used till recently, and now it has been like a four-step ladder in case of adults. But in pediatric, we only have two-step ladder, in which step one is of mild pain. And mild pain, I say it is like a pain scoring of 1 to 3 comes under mild pain. And step two is for moderate to severe pain, in which we have to use opioids. There is no middle step where you use weak opioids. So this is regarding what I was telling. Step 1 is used for mild pain. Here the medications that can be used are paracetamol and NSAIDs. The NSAID which we commonly use is ibuprofen. Step 2 is used for moderate to severe, and one like major drug which we use at our center is morphine. Apart from morphine, we can use fentanyl and methadone as well. One point is we have to avoid weak opioids such as tramadol and codeine. Codeine is not available at our setup. Tramadol is, according to WHO guideline, is better to be avoided in children. And if a center doesn't have like the strong opiates, or they have to use tramadol, it has to be used with caution in children about 12 years as well. And below 12 years, it is better to be avoided because there's lack of evidence and concerns about safety in children. And tramadol as such also leads to decrease in threshold of seizures. So tramadol is avoided. So regarding step 1, again, non-opioid pain medications, paracetamol can be given 10 to 15 mg per kg every 4 to 6 hourly. And the Brufen can be given at a dose of 10 mg per kg per dose every 6 to 8 hourly. So any child on assessment on numerical scale here with a pain of 1 to 3 can be started with a non-opioid pain medication, that is paracetamol or ibuprofen. Coming to step 2, like we already told regarding strong opioids, so the medications that can be used is morphine, methadone, fentanyl. I have also mentioned regarding other pain medications such as hydromorphone, diamorphone. These are like not available in India, so I won't go into detail with that. So this is just a small scenario. So you're caring for a 14-year-old boy with metastatic osteosarcoma. While he is admitted to the oncology ward, he develops severe pain. What is the best medication to treat his pain? Options are IV pethidine, IV paracetamol, per-oral tramadol, per-oral paracetamol, and per-oral morphine. So here in this question, we are talking about he has developed severe pain. So the pain medication which we have to use is a strong opioid. So we can start with a per-oral morphine for this child. So at times when a child is complaining of severe pain, we can also give the child a sub-Q morphine because the action takes less time and we can relieve the pain immediately. The other principle is by the clock. So when the pain is constantly present, pain medications should be given at regular intervals. Like I told, like for few medications, for example, NSAIDs, it can be given 6 to 8 hourly. For morphine, it has to be given 4th hourly. So it depends on the kind of medication you're giving. And we need not follow like precisely, like if the child is complaining of pain like before the time of like dosage, we have to not wait till the uh, like the next dose. We have to give the dose immediately to relieve the pain. And waiting too long between the doses actually could make the pain go bad from worse. So what we have to do is we have to keep in mind regarding the PRN or SOS doses, and we have to increase the amount of pain medicine whenever needed to lower the pain. And like I said, an extra dose can be given if there is breakthrough pain between regular doses. So in the coming slides, we'll be showing how morphine prescription looks like and the timing when it can be given. So what is a breakthrough pain? Any pain that is like sudden and unexpected that occurs when a patient is already like taking opioids. So whenever a patient is taking like opioids every fourth hourly, for example, a patient is on opioids, like immediate release opioid from like 6 a.m., 10 a.m. So if there is a pain that occurs at 8 a.m. or 8:30 a.m. or any time in between, that has to be taken as a breakthrough pain, and you have to give a PRN dose. So PRN dose is an SOS dose, that is same dose as a regular dose, and in few setups, half of the regular dose is also tried to relieve the pain. And breakthrough pain is very common in cancer patients. Around 40 to 80% of cancer patients have breakthrough pain each day, according to studies. So this is what we were talking about. Morphine should be given every 8th hourly. So recommended timings is 6 a.m., 10 a.m., 2 p.m., 6 p.m. And like we can also give 7 a.m., 11 a.m., and 3 p.m. So it depends whichever you're comfortable, but you have to like uh, fix to a proper timing so as to like explain to all the staff. And we give a double dose at 10 p.m. because we don't want to wake the child up, and we want the child to have a good 8 hours of sleep. So we um, uh, like whenever we are giving opioid, it is best to give a double dose at 10 p.m. And like we told, SOS dose, it is same as the regular dose. The fourth principle is by the mouth. The pain medication should be given in the most effective, least painful, and in the simplest form. And oral is the most convenient way of giving opioids. And occasionally, if a patient is not able to take oral medications, or when a patient is in severe pain and you need to like uh, relieve the pain immediately, IV or subcutaneous opioids can be given. And always try to like never give IM dose because it is very painful. And we have better alternatives such as IV and subcutaneous. So in all patients, we can use the subcutaneous routes. There is like almost no contraindications for subcutaneous routes. So it should be either IV or subcutaneous if it is not oral. And the next principle is by the individual. So here what we need to remember is we need to speak to the child directly how he or she is feeling, and dose of morphine could be adjusted according to how the pain relief is. And if pain is poorly controlled, we can increase the dose by 25 to 50%. And for strong opioids such as morphine, there is no ceiling effect. So you can slowly increase and go up on the dose. So there is no maximum dose of strong opioid. And our goal is to provide the best possible pain relief with the side effects that are tolerable to the patient. So if the patient is having like increased side effects or is becoming intolerable to our opioid, even though is having good pain relief, so that is not a good way to go ahead. So whichever side effect is tolerable to the patient, to that limit we can go. And one major thing is we need to communicate if pain treatment is adequate or not. So whenever we are starting a child on pain medication, we tell the parents that we are going to come back and we are going to reassess the child in 1 hour or like 2 hours. So according to the degree of pain. So whenever we are giving oral medication, if a child is in severe pain, we tell them that we come back to you in an hour and a half, and we'll ask them we to know like to what extent the pain relief is. And always have open-ended question regarding how the pain is, and based on that you can like increase the dose or continue with the dose. And if the patient is awake and complaining of pain, you can always give an extra dose of morphine, like we have told an SOS dose or a PRN dose. So whenever a child is complaining of severe pain, you stay there and like give an extra dose so as to see the child is having proper pain relief. So this was regarding principles of morphine. Now coming to how to safely and effectively prescribe morphine. So there are some false beliefs about morphine and myths. So I'll just go regarding the myths and facts. So there's a myth that we have to withhold morphine for the last days of life. But the matter of fact is, give morphine for a good, for severe pain, for a good pain relief. So when there's a good pain relief, the quality of life improves, and the end of life is better. Because if there is pain and discomfort, the end of life is very troublesome. And the dose can always be increased. Like we told, there is no ceiling effect. So you can give the dose which is maximally tolerated by the patient with the least side effects. One more myth is morphine hastens death, but according to few studies, palliative care can prolong life, and morphine ensures good quality of life with relief of suffering. One more myth is morphine causes addiction. Uh, there's a physiological antagonist of morphine, that is pain. So patients who have pain and like are suffering with pain, they almost never get addicted to morphine. And children cannot tolerate opioids is a big myth. Morphine can be used safely in children. So this is regarding regular oral morphine doses. So in adults and in pediatrics, actually all the medications are based on per body weight. So children with more than 25 kgs, we can start a dose of 5 to 10 mg every fourth hourly. In children like more than 1 year, we can give a dose of 0.2 to 0.3 mg per kg every fourth hourly, according to the weight. And if it is an infant, we go with a lesser dose of 0.08 to 0.2 mg per kg every fourth hourly. And if the pain is poorly controlled, we can always increase the dose by 25 to 50% of the SOS dose. Coming to IV or subcutaneous morphine. So this is IV or subcutaneous morphine is always 2 to 3 times more potent than the oral morphine. So if I'm giving a oral dose of 5 mg in a child, we can give 1.5 mg every fourth hourly IV or subcu. So it depends on the amount of like the weight, as well as it also depends on what oral morphine patient is on. But if you are starting an IV or subcu morphine for severe pain immediately on seeing the child, we can start with 0.1 mg per kg every fourth hourly. And in case of infants, you can uh, use the same from one month to 1 year. You can use the same dose of 0.1 mg per kg, sorry, every fourth hourly. But in case of neonates, you go like half the dose of what is recommended for infants, which is 0.025 to 0.05. And this can be given every sixth hourly instead of fourth hourly. So apart from immediate release, we have sustained release oral morphine as well. And the duration of action of sustained release is 8 to 12 hourly. So like unlike adults where you keep sustained release every 12th hourly, we can start a child on sustained release after knowing what the immediate release morphine dose is. We can divide the total dose by 2 and we can start the sustained release formulation. And like like it is told, it is not appropriate as an initial pain management. So since immediate release provides immediate relief, we have to start a child on immediate release morphine, and based on the response and based on the uh, like if a pain is stable, then we can convert the immediate release to sustained release, and only use after patient has been stable dose of morphine for at least 5 days. So these are the
Ishak, you
different,
have, sorry, Ishak, for interrupting.
yeah,
You have around 3 to 5 minutes.
yeah, okay, thank you. So coming to opioids used for moderate and severe pain. So here I just want to tell regarding that peroral and IV dose. When you see, you can see that peroral dose is 0.2 to zero point 0.3 and IV or sub-Q dose is 2 times or 3 times less than the oral dose. And fentanyl can be given in an interval of 30 minutes or it can be given continuously as well. So the dosage is same for like continuous infusion, which is zero point 0.1 mcg per kg per hour. So if you are giving every 30 minutes, it is almost the same dose or half the dose of fentanyl. And methadone is another very good drug, which can be started orally as zero point 0.1 mg per kg. So methadone is started whenever we know proper dose of morphine is like when we have a regular dose of morphine and we want to like convert, that is when we shift from morphine to methadone. We don't start methadone directly. Till now I haven't started methadone directly, so it is always morphine unless and until we have to uh, if morphine is contraindicated, then we go to methadone directly. So this is a small case regarding a 6-year-old girl with AML. She has relapsed with bone marrow transplant, and you assess at home, and she has significant limb pains related to bone marrow infiltration. She's having severe pain, and it is not getting controlled with acetaminophen and ibuprofen. So how do you treat her pain? She's 20 kilos. So this is just to have a proper calculation regarding how to start an opioid. Since she is in severe pain, we go with step 2 of WHO ladder. So oral morphine can be started with 0.2 to zero point 0.3 mg per kg per dose. So based on her weight, we are getting a dose of 4 mg Q4H. So in Nepal, I know that there is availability of syrup. So you can just put the child on like 4 mg, which is 2 ml of morphine. And you can also give breakthrough doses, explain them that breakthrough doses are to be given. And that is how you can like control her pain. So what should we teach the patients about taking pain medications? So there are 6 key points. So we have talked about how to take morphine. So better to be given orally. So each child will be requiring a particular amount. What we do at MNJ is if a child is to be given 2 mg of morphine, we just take a tablet, mix it in plain saline or water, and we tell them to how to like how to give the doses. We ask them to we mix and give it to them, and we also empower them how to mix it whenever it is needed, and we tell them in quantity of mls so that they don't get confused. Other counseling point is we have to tell them regarding the precautions that are to be taken regarding how it is to be given as well. Whenever there is additional pain, increased pain, you have to give one more dose. You have to tell. Regarding side effects, so opioids can cause nausea, vomiting, constipation, which we'll be dealing in the coming slides. So we have to tell them regarding these side effects so as to they are like prepared and they don't stop the medication when these side effects come, fearing for the child's health. And for increasing pain, we have to tell them to contact the doctor or the health professional or the nursing staff, whoever is available from our team. And we have to also tell them regarding how to use the SOS dose. So these are the side effects: nausea, vomiting. So whenever a patient is complaining of nausea and vomiting, it is a good practice to give metoclopramide or haloperidol. Ondansetron does not work for nausea and vomiting. That is because of opioids. One another major uh, side effect is constipation, and we have to be careful when we are prescribing morphine. We have to give a stimulant laxative because constipation as such can trigger seizures and dystonia in children with severe neurodisability. Another side effect is sedation, which is generally mild and only lasts for several like uh, days, and we have to decrease the dose accordingly. So I'm trying to go a bit fast because of time constraints. So apologies for that. Coming to opioid toxicity. So the signs of opioid toxicity are respiratory depression. Uh, uh, like oral doses of morphine doesn't cause respiratory depression or distress or breathlessness. So respiratory depression, you have to see what the respiratory rate is, and if it is below 12, you have to be cautious in children. The other signs are pupillary constrictions, myoclonus, and extreme sleepiness. So when these signs are there, the treatment of choice is naloxone with a duration of action of 30 to 60 minutes. And we have to give naloxone till the patient's respiratory rate comes to normal. Coming to the last part of my discussion is regarding procedural pain management. So there are four essential components of any procedural pain management, such as positioning, distraction and integrative therapies, topical anesthesia, and sucrose. So regarding positioning, appropriate positioning and holding are very important to provide proper procedural pain. So in this, you can see the mother and father is holding the child back to chest in bear hug position and chest to chest hug position. So as to make the child comfortable and reassured. We have to avoid supine position as it increases pain as well as it makes the child anxious. Another major part is distraction or integrative strategies. Distraction reduces anxiety and can improve comfort, and it varies from child to child how we use distraction techniques. So for infants or young children, breastfeeding, swaddling, kangaroo position, kangaroo mother care position, or dimming of light or noise, and usage of small toys or bubbles is a very good way for distraction in case of infants and young children. For older children, you can ask the parent what has worked before for them and what do they think would help. Video games or games on phone or tab is very helpful, and storytelling, talking, and reading books is also very good distraction technique. And relaxation techniques such as deep breathing and mindfulness regarding the procedure also makes them less anxious regarding the procedure. Coming to topical anesthesia, so whenever we are giving a needle procedure, uh, like giving a topical anesthetic is a thing which we have to do for every child unless and until they refuse. So one example is EMLA creams, which is
Ishak,
eupectic mixture of lignocaine and
Dr. Ishak,
yeah,
it's like the last 1 minute, please.
yeah, okay. Um, so we can use EMLA creams, which take around 45 to 1 hour to act. So this is something which we have been using in our practice. So EMLA is nothing but lidocaine and prilocaine, 2.5%, and the minimum application time is 60 minutes, and it uh, gives a duration of action of like 1.5 hours to 2 hours. So these are the steps where you can see we are just applying EMLA cream on the like lumbar spine. So this is how we can do it. And the last thing is regarding sucrose. So sucrose is effective in managing mild to moderate pain and in children, and it can be used from 0 to 12 months and not only in newborns. It reduces pain and crying during painful procedures. And sucrose can be given 2 minutes prior to procedure, and the duration of analgesia is 4 minutes. So once the dose is given, you can again give a dose if you feel the procedure is taking longer. So these are the last slide where these are different suggested means of pain reduction. So heel lancing is heel prick. So you can breastfeed the child, or you can give skin to skin care, or you can ask the mother to hold or swaddle. Swaddle is nothing but wrapping the infant in blanket or similar clothing to limit the movement. And you can also give oral sucrose. And similarly for NG or OG tube, we can follow the same steps. You can give a non-nutritive sucking. So any sucking that is where fluid is not introduced is non-nutritive sucking, and children normally suck on empty breast for comfort as well. And for PICC line as well as peripheral arterial line, these are the things that can be followed. I'm not going into detail. And yeah, so these are the various ways where by how we can like decrease pain in children. With this, I end my session. Thank you.
Thank you, Dr. Ishak. That was very good session, and you covered all the points. And I'm really